Well, I'll mention cancer-associated thrombosis. As we know, cancer does predispose patients to almost 4 to 7 times increased risk of VTE and almost a 10 times increased risk of death. So the guidelines that I'd like to mention are the ones by the ISTH, International Society of Thrombosis Hemostasis, the NCCN, and the ASCO guidelines. And they really center around ensuring that all of our inpatients receive appropriate prophylaxis unless there's a contraindication, and also focus on primary prevention. And what I'm talking about when I refer to primary prevention is really our outpatient primary cancer patients who are starting chemotherapy should and could be initiated on oral NOAC therapy for up to 6 months. And so I think that's some of the newest guidelines as it relates to cancer-associated VTE. Now, when it comes to treating a VTE in patients who have malignancy, we have 3 very good studies: the Hokusai VTE cancer study, the Caravaggio, and the SELECT-D study. And so those 3 studies in combination provide the basis of guidelines for the secondary prevention of VTE in patients who have cancer and the use of NOAC therapy, and in some cases preferential over low molecular weight heparin therapy. So what I'll say is that within the guidelines, we're seeing a lot of progress in the area of ensuring that we have some consideration of primary prevention in our outpatients with cancer, and also ensuring that we use NOACs for secondary prevention of VTE. Well, it's my opinion that NOAC therapy should be first-line therapy for patients who have a VTE, unless, of course, there is a contraindication such as a drug-drug interaction or perhaps even advanced renal insufficiency. On the prophylaxis side, as mentioned, Magellan provides strong clinical evidence and an FDA-approved drug for the 10 milligram dose in patients who meet criteria based on Magellan to use oral prophylaxis therapy when patients enter the hospital and continue that up to 35 days, even after they leave. As I mentioned, there is a significant relative risk reduction in the rivaroxaban arm, up to 32% relative risk reduction, with almost an equivalent percentage of bleeding as it relates to major bleeding, 0.7 versus 0.5 in the current standard of care. And so those would be some of my thoughts on the use of rivaroxaban in patients who have a VTE or for primary prevention of VTE. Well, what we know is that the COVID pandemic has put VTE in the forefront as an important prevention strategy. And what we know is that there's likely some increased risk in patients who have COVID to have a VTE. And some of those are traditional VTE risk factors, such as immobilization. And some of them are indirect, related to, for example, the severity of a patient's illness, or even direct effects. COVID has been known to enter the endothelium and cause a procoagulant state. And as we know, there are significant inflammatory markers that rise when patients have COVID, such as CRP and D-dimer. And so what I could say is that at this point, there's a significant variability within the VTE COVID literature on the use of prophylaxis as it relates to treatment dose, a higher dose, but certainly within the realm of the use of prophylaxis for prevention at the standard prevention dose, there is significant evidence that we should do so. Now, there is significant variability in the literature for treatment dose based on disease acuity, study settings, as well as a variety of other factors. And so whether we'll use treatment dose for VTE prevention in the future is yet to be decided, but certainly for prophylaxis, it has affected my daily practice where I think about this condition often. I do risk severity assessment, and I ensure that my COVID patients are on prophylaxis unless there is a clear contraindication. Well, my key takeaways are that we should always be thinking about prophylaxis in our patients. Certainly, we have parenteral prophylaxis as an option, but now we have oral prophylaxis options, specifically as mentioned, based on the Magellan and its subgroup study. We have a 10 milligram rivaroxaban dose. And so I think those are important advances in the area of VT. And once again, to emphasize the the COVID pandemic, it's critically important that we ensure we have appropriate prophylaxis for our COVID patients. And whether we choose treatment dose prophylaxis for these patients is yet to be decided.